welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Tyler Brown, who will be talking to us about sexual health and intimacy with MS. After his presentation, we'll open it up to your questions and comments. Now I'm delighted to introduce our speaker. Tyler Brown, Psy.D, joined Shepherd Center in August 2020 as a rehabilitation psychologist. He earned his Bachelor of Science in Psychology at Lander University in Greenwood, South Carolina. He earned his Master's in Science in Psychology at Augusta State University before continuing his graduate education and earning a Master's of Science in Clinical Medical Psychology and his Doctorate in Clinical Psychology at Mercer University in Atlanta, Georgia. He completed his clinical internship at Wichita State Counseling Center at Kansas University School of Medicine, Wichita, and as part of the Wichita Collaborative Psychology Internship Program in Wichita. He completed his postdoctoral fellowship at MedStar National Rehabilitation Hospital in Washington, D.C. Dr. Brown is an adjunct professor at Mercer University. He also has a passion for providing evidence-based treatment to individuals and their families dealing with a variety of complex medical conditions, including spinal cord injury, acquired brain injury, multiple sclerosis, chronic pain, and amputation. We're very pleased to have him join us today to present this interesting and helpful information. Doctor, thank you so much for being with us today, and now I'm going to turn it over to you.
Thank you. I just want to welcome everybody. I'm glad you got to attend, and I really hope that you get something useful out of this presentation. I'm having a little bit of a technical difficulty today where I can't share my PowerPoints and my screen at the same time. So this is the last chance you get to see my pretty face until the end of the presentation for the Q&A. So let me go ahead and share my screen here real quick. Can everybody see that okay? Okay. So today we're going to be talking about sexual health and intimacy, particularly in multiple sclerosis. In terms of disclosures, I don't have any disclosures, so there's really nothing to talk about there. So we'll go ahead and continue. I just wanted to go over some very basic learning objectives that I have for us today. First, I'd like to discuss sexual health broadly and just talk about ourselves as sexual beings, the role that sex and intimacy plays in our lives, very briefly. Then I want to go on to discuss sources of sexual dysfunction and intimacy that are specifically challenges to people dealing with MS. Have a more broad discussion of a lot of the different types of treatments that are available for those sources of dysfunction. And then we'll have a more specific conversation, myself being a rehab psychologist, of some of the things I'm a little bit more in tune to. So some of the behavioral and psychological interventions that can help people that are having intimacy or sexual health issues. And then finally, I want to discuss some resources for further exploration consideration. I'm a big fan of, these 1 hour talks are very important, but I always want to make sure that I have something extra for you to go home with and to explore and do some of your own self-exploration with. So I always think that's important. So we'll end with that. So just in terms of talking about intimacy and sexual health, Oxford Dictionary defines intimacy as a close familiarity or friendship or closeness. So I think another way to say this is intimacy can be a part of sex, but intimacy can be something completely removed from sex. So sex often involves intimacy, but intimacy doesn't involve sex. So intimacy very broadly, we often talk about denotes mutual vulnerability, so being vulnerable with another person, and even in some cases being vulnerable with ourselves, having an openness to new experiences, and to be able to share with another person or with ourselves. It is often present mostly in our closest loving relationships, right? So that includes marriages, romantic partnerships, but that also extends into things like friendships and family relationships as well. So the term is often used interchangeably with sexual interactions, but I do want to point out that intimacy doesn't necessarily have to mean sex. So one of the biggest issues that we'll get into as it comes to discussing sexual intimacy, discussing treatments, is that there's a lot of societal perceptions of sex that often make it difficult to discuss, and that embarrassment can oftentimes be a very common feeling that people have when it comes to either discussing sexual intimacy with a partner or with a physician or with a psychologist. It's something that we're taught is kind of taboo, and you're supposed to kind of keep that to yourself or keep that just between you and your partner. And that can really be a barrier to successful treatment. One of the things I really want to highlight, and I hope comes across, is sex is totally normal. It's a part of life. It's a part of our development. From about the time we hit puberty, we start to become interested in romantic relationships and dating. Sex is usually part of our lives in adulthood, and it might wax and wane at different points in our life, but sexual activity is very normal throughout the lifespan. To the point now, like I was even having a conversation recently, I've counseled sexual health on people in their 70s and their 80s. So it's very common, very normal across the entire lifespan. Very briefly, I just want to say something here about anatomy. So as we start to talk about what we'll call primary sexual dysfunction, it's important to understand that in utero, as we develop, you start off as just an egg before it's fertilized, and you have an X chromosome from your mother, and then your father either gives you an X chromosome in which you'll develop into a biological female, or a Y chromosome in which you'll develop into a biological male. The nerve endings that ultimately become our genitalia are basically the same nerve endings that we are when we're just an egg. So just to understand that our sexual response is very similar, even though the appearance of our genitalia can be really different depending on if we're male or female. And that sexual activity or sexual functioning within an individual isn't just about genitalia, but it's a relationship between the central nervous system, which is our brain and spinal cord, and our genitalia. So just like our brain is the main hub or relay for our heart rate and our breathing
yes, I will do allowance in a
and
minute.
our perceptions of different things, it's also vital here as well.
Hey, baby.
And we'll talk a little bit more about them.
I do need to send the girls.
Sorry. So when it comes to sexual dysfunction, what we know with MS based on research is that it impacts about 50 to 90% of men and 40 to 80% of women with MS. So it could be a very common problem. Depending on how we ask about sexual dysfunction can affect those ranges. So that's why there's such a broad range there. A lot of it depends on how we ask participants in studies about their sexual health. Sexual dysfunction can be broken down into multiple categories. So we'll go a little bit more depth into each of these, but just a basic definition. Primary sexual dysfunction has to deal with direct sexual dysfunction or direct sexual functional changes that are associated with lesions in the brain or the spinal cord. So lesions in the brain or the spinal cord directly influence your ability to have sensation in your genitals, or they'll affect your ability to have an erection. Those are primary sexual dysfunction. Secondary sexual dysfunction is sexual dysfunction that's caused by neurologic symptoms, but they're not necessarily directly related to sex. The most common one of that is going to be fatigue. So even though your general energy level doesn't directly relate to sex, and it relates to more than just sex, if you're experiencing fatigue, chances are your desire or drive to have sex are going to be diminished. So those are the secondary sexual dysfunctions. And then we'll talk about tertiary sexual dysfunctions. That's kind of everything else. It's the internal and external psychosocial factors that are related to MS, but then wind up impacting sexual feelings and response. So things like anxiety, depression, relationship issues, communication issues with spouse and loved ones. Those are the types of things that fall into that category. Some of the big things that we'll discuss as it relates to that primary category is reduced libido, so sexual drive or urge. A lot of our drives or urges, especially as it relates to sexual desire and drive and urges, is actually a very complex neurochemical conversation, if you will, between our brain and our spinal cord and the rest of our body. Reduced sensation in the genitals is another primary reason why people have a disruption in sex. So the numbness that you might experience in your body can extend to the genitals. Erectile dysfunction in men is like the most common reason for sexual dysfunction as it relates to MS that has neurological underpinnings. So again, the reason men obtain an erection is because of stimulation in the spinal cord. And one thing I didn't say earlier is the very bottom of our spinal cord, our tailbone, is where the nerve endings that help control sexual functioning are. And so any impairment above that, which is pretty much everything, can disrupt the system below it, right? It's like if there's a traffic jam on an interstate, from that point moving forward down the highway, nobody's getting through. So if you want to think of it like that. And so that's where some of this dysfunction can come from. You might have a lesion higher up in your spinal cord or in your brain, but it's disrupting all the signals below that level. And our sexual functioning is sort of the last stop on our spinal cord. Another thing to point out here is that primary sexual dysfunction has a high correlation between urinary problems, so like bladder problems, urinary incontinence, and in women, pelvic floor weakness has a high correlation with sexual dysfunction. And that's because our bladder functioning and those pelvic floor muscle functioning is also tied to those sacral nerve endings at the very end of our spinal cord. Reduced lubrication in women is another big issue. It's kind of the inverse of erectile dysfunction in men. And another big one is an inability or reduced ability to achieve orgasm. Before we talk about treatment, we'll talk about the common types of dysfunction in each of these categories. So secondary sexual dysfunctions that are very common in MS, I already named one, and it's the big one, is fatigue. Obviously, it's one of the major symptoms or major components of MS, but it can impair sexual functioning and intimacy as well. Muscle tightening and weakness is another major complaint. Allodynia, which is a sensitivity to touch. If you've ever known anybody with fibromyalgia, that's like that type of sensation. It's technically a type of like neuropathic pain, but where just like normal touch to the skin can be painful or very sensitive and unpleasant. Muscle spasms can play a major role, as well as spasticity, so that tightness or that rigidity of the muscle. Tremors, different types of pain, tingling, burning sensations, so like neuropathic pain or different other types of pain, like lower back pain, things like that can play a role. Attention and concentration, so your ability to kind of be able to attend to the moment, to concentrate on the moment, so the cognitive issues that are very common to MS. Physical and mobility limitations, so actually like the ability to position or to function the way that you might normally function when you're having sexual relations. And the other one I already mentioned, like bowel and bladder incontinence as well. So that often is related more to like feelings of embarrassment. There's a fear or anxiety there that like I want to engage in sexual activity, but knowing that I'm prone to having these types of accidents, I don't necessarily want to engage in sexual activity. I might be scared of having an incontinent episode, for example. For the tertiary sexual dysfunction, like I said, this is kind of everything else. Depression is very common in MS, and depression can cause a reduction in libido. A very central symptom in the diagnosis of depression is what we call anhedonia, which is a loss of desire or the loss of a desire to want to participate in meaningful activities. And oftentimes when people suffer, especially severe or moderate to severe depression, they just lose a desire to want to do anything. And even things that brought them desire before just seem like they're not going to help or that you want to participate in those things. And so that can include sex and intimacy as well as it can lead to increase in social isolation, not wanting to participate in relationships, not wanting to be around people. Anxiety and fear, and this can be manifested in multiple ways. It could be just generalized anxiety about the situation, going back to the incontinence. It could be specific anxieties about that. It could be anxiety or fear about abandonment or about rejection. It could be fear of sexual performance, so thinking that you won't perform well or that the other person won't find what you're doing satisfying. So that can be many different things. Changes in family roles can often impact sexual health. I think the most salient example of that is all of a sudden your sexual partner becomes a caregiver, and they might be participating in levels of care for you that they hadn't participated in before. And that can often create boundary issues that make it difficult for you to maybe feel like a sexual person, or for your partner to feel like you're a sexual person, or even a perceptual, like a cognitive distortion or perceptual issue of there's no way my partner can see me as a sexual person anymore because they're providing this kind of care for me. As related to that too is sort of that changing or that feeling of dependency can rob us of our feelings of being a sexual being or being an independent being. And feelings, our own relationship with ourselves, how we feel about ourselves, our self-esteem, our self-worth, our body image, and our sexual image is usually directly related to our body image, right? How we feel about ourselves. Do we feel sexy? Do we feel like we are attractive to other people? So the good news here is that there are a variety of treatments that exist for the issues that we've already talked about related to sexual dysfunction. And broadly speaking, people with disabilities, not just people with MS, but including people with MS, can adapt and learn to have very healthy and fulfilling intimacy and sexual health. And I would say across the spectrum of populations I've worked with, spinal cord injury, brain injury, MS, whatever it may be, I've worked with people who have gone on to have healthy sexual relationships. So it's certainly possible. And oftentimes people become so frustrated that they sort of lose hope in that and they stop trying. So that's one thing I want to instill in you today, is a sense of hope that you can recapture that. So for people with acquired disabilities, I think one thing that's important to point out here, so things like spinal cord injury and MS, there's often an emotional adjustment that doesn't necessarily happen with people that might have congenital disabilities. So they've spent their entire life with that disability. They were born with it and they've adapted with it. It's the only thing they've ever known. For people with acquired disabilities, there's an emotional adjustment that happens, and it's judgmental. That's a comparison of your former and current self, right? So you have an expectation based on what you were previously able to do versus what you're able to do now. One thing I will say is that treatment often involves a degree of openness to explore new possibilities. So for a lot of people that go on to develop a new sexual identity or redevelop or recapture their sexual identity, they have that sexual identity, but their concept of sex, their concept of intimacy might change. And the last thing I'll say is treatment often involves a multidimensional and multiple disciplinary approach. So as you solve the types of dysfunction that I mentioned, you very well might have identified with one thing, or you might have identified with multiple things. And depending on the sources of those dysfunctions, you might need, there might not be a one size fits all treatment for that. You might wind up going with multiple providers in different professions. You might need some psychological intervention or working with a sex therapist or working with a couples counselor paired with medical intervention that includes medications or paired with occupational and physical therapy to be able to make the adaptations that you need. So there can be some trial and error, and that kind of gets back to that idea of openness. There can be some trial and error due to the complexity of the issues. And one thing that might work for person A might not work for person B. So you might have to go back to the drawing board and say, okay, this didn't work so well. What's the next thing we can try? So patience can be a really important part of this as well. So getting back to the notion of primary dysfunction, let's talk a little bit very broadly of what some of those treatments might be. So when it comes to things like reduced libido, so that general sexual drive or urge, a lot of what the treatment might be is going to be dependent on what the diagnosis of the source is, meaning there's just not one thing that could be reducing libido. So an example of that is if you have a reduced sexual drive due to depression, well, that could be treated with antidepressants or therapy. Versus if you have a reduced libido or sex drive because it's related to fatigue or energy, there are other medications such as modafinil, Provigil, are two that are commonly listed in the studies that help with energy needs. Though modafinil, for example, is a medication that's used to treat like sleep disorders, like narcolepsy and things like that. But it also can help with like energy levels and things like MS. So that's been used and quoted in the research as a potential treatment. Behavioral activation of sexual activity. Again, this kind of comes back to the idea of depression. So behavioral activation is an old school psychological treatment for depression that involves just engaging in the activity. So oftentimes people say, well, that's not fun for anymore, so they just stop doing it altogether. And what we know about depression is if people make a commitment to re-engage in those activities, sometimes they derive pleasure from it, and that can help build your mood back up and can help get you re-interested in those things that you might have stopped doing. And hormone treatments are sometimes quoted in the literature. I put a little bit of an asterisk there because sometimes, depending on the situation, hormone treatments can have some controversial underpinning. So that's something that you would have to talk a little bit more about your physician about if that's an appropriate treatment for you. When it comes to reduced sensation in the genitals, or if you have a reduced capacity to orgasm, focusing on other erotic areas not affected by touch. So like when I work with spinal cord injury, people who might have a total loss of sensation below a certain level, when they recapture their sexual identity, they'll often find themselves focusing on other areas so that sex becomes less of a hyper focus on penetrative intercourse and more on other things. So like touching other areas that stimulate a sexual response. So if you think back to maybe even times earlier in your life when you're dating and before you started engaging in sexual activity, other things that you might have found exciting, like kissing, attention to the neck, nipples, those types of things will often be a focus to be able to achieve arousal. Mental arousal exercises, one thing I encourage you to take away from this is to think about not only your genitals as a sex organ, but your brain as the ultimate sex organ. So we've already talked about how it directly and neurologically affects your ability to have sexual arousal and to become physically aroused. But if you go back, and chances are at some point in your life, you might have had a sexual fantasy or a sexual dream, or maybe when you were masturbating, just a sexual fantasy or something you conjured in your mind, you were able to use your mind and your imagination to become aroused. So using arousal exercises and mental arousal exercises can be a good treatment for this as well. With reduced sensation, if assuming that it's a reduction and not a loss of sensation, a lot of research has indicated that the use of vibrating devices, something that creates a more intense signal to the area that you're trying to arouse, that using those devices can work really well. For things like erectile dysfunction or reduced sensation, digital and oral stimulation. So participating in other types of sex, whether it be using your hands or oral sex, and those types of things can be very beneficial. And there is one, I think it's an FDA approved treatment in women. It's called the Eros therapy system. And in a minute, I'm going to talk about vacuum pumps for men, but it's essentially a vacuum pump for women that manually uses physics to draw blood into the clitoris so that the clitoris becomes engorged the way it would normally be by sexual arousal. But it's just a way to stimulate that if you have trouble with that. So with erectile dysfunction in men, there are certain medications, and the medications that work for erectile dysfunction without MS or without a disability often work in MS as well. So the big gold standard obviously being Viagra. Sometimes that can be effective. And to think about like the different levels, it really depends on, like, medications is going to be like the first line treatment. A second line treatment, if you don't respond well to medications, are injections. It's a medication that's very similar to what's in Viagra and Cialis, but you actually you inject it directly into the penis. And so, for example, like spinal cord injury patients or people whose MS maybe have progressed to the point that they don't have any sensation, but they still want to have sexual activity, this can be a good option for them. Vacuum pumps, similarly, they work by, it's a pump that you place over the penis, and it creates a vacuum seal that forces or draws blood into the penis. And then you use these bands that keep the blood from coming back out. And so you can keep those bands on for about 30 minutes of sexual activity. And so it can help you maintain an erection if you otherwise cannot. And there are surgical implantations that are common in spinal cord injuries that have been used in MS, but those are extremely rare. They're obviously invasive. One involves inserting a metal rod into the penis that creates an erection, and the other one is an internal pump that actually sort of pumps up the penis to have an erection. For women with decreased lubrication, which is a very common neurological issue associated with MS, hormonal treatments have have been shown to be effective in research. The use of water-soluble lubricants, which you can either get, I think, from requesting from your doctor, or you can get it like adult shops. Those can be effective to create lubrication. And I put a question mark next to medication because there are some studies that suggest some of the medications that are designed for male erectile dysfunction, like Viagra, can help increase lubrication, but it might not necessarily be the best option, because some of the other options are going to be cheaper and more available. So they might be better options than going to something like that, because the research in that regard has been very mixed. When it comes to secondary dysfunction, fatigue, muscle weakness, and mobility, a lot of the things I'll often recommend people on, I think we can kind of get stuck in like, okay, sex is something that maybe happens at night, after we lay down and go to bed. I encourage people to like think about your schedule and have sex fit around your schedule, not fit your schedule for sex. So, for example, if you have more energy in the morning, or if you have more energy after an afternoon nap, those would be good times to initiate sexual activity when you have the most energy or you have the most desire. So including like planning sex after you've had a nap or after you've had rest. Positions that require less dexterity or effort. So for the person that has the disability or has the muscle weakness, positions like being on bottom or propping yourself up against furniture and using furniture, or side by side, those can be positions that require less energy and less muscle than like traditional positions like missionary, being on top. When it comes to spasm, spasticity, and tightness, a lot of the anti-spasticity medications, you can use those closer to sexual activity so that you have a greater effect. So things like baclofen being probably the most common. Botox injections are something that are often used to treat spasticity, as well as participating in physical and occupational therapy. So when people participate in those types of therapies, you're often giving exercises and stretches that help reduce spasticity and tightness in your muscles. So engaging or pairing those exercises prior to sexual intercourse can often be very effective. When it comes to bowel and bladder dysfunction, some really good tips here: avoiding diuretics, anything that's going to be more likely to make you want to go to the bathroom. So avoiding alcohol, caffeine, and tobacco. I put a question mark next to artificial sweeteners because from my kind of limited understanding, artificial sweeteners aren't technically a diuretic, but they do have an effect on bladder functioning to where they can like irritate the lining of the bladder, and they can potentially create an urge to want to pee more. So that could be something else you might want to consider to avoid or to experiment with if you're having those types of issues. A big one that's very common recommendation is just making sure that you're doing your voiding close to sexual activity. So if you know you want to engage in sexual activity, go ahead and get your voiding out of the way so it's not going to be an issue. If you have an indwelling catheter, if a lot of times people will choose to undergo surgery to get a suprapubic catheter, which is inserted, above the genitals and directly into the bladder. So that can remove the need for an indwelling catheter to be able to engage in sexual activity. Or moving, for women specifically, so this doesn't apply to men, but moving an indwelling catheter to the side is another option, or like taping it up so it's out of the way. And one of the things that research pointed out that physicians will often find is sometimes women can have kind of a poor understanding of their own genitalia due to kind of societal or taboo reasons. It's important to understand that your urethra and your vagina are totally separate orifices. So you can have an indwelling catheter and potentially still engage in sexual activity. They're not occupying the same space. When it comes to pain, tingling, burning sensations, or more different forms of chronic pain, semi-time planning, so trying to plan sexual activity around the times of day when you might experience the least amount of pain. When it comes to direct sexual pain, where you might have pain during intercourse, there are actually local topical anesthetics that can be prescribed to you that'll numb the area or numb the sensation to where it's not as painful. Obviously, the use of pain medications prior to activity, modified positioning. So some of the positions I mentioned earlier, plus like I know people will often use things like a pillow under the lower back to take some tension or pressure off of the lower back. as well as like if you go to like adult shops and things like that, there are like special wedges and things that are actually meant to help prop up the back and give additional support. And one thing that's been changed a lot of people's lives with disabilities are what's called sex slings. They're these like slings that you actually harness into that hang from the ceiling that make accessibility and mobility a lot easier on an individual. And those are extremely popular among people with disabilities who engage in sexual activity. Another thing I'll say here is, especially for women, a lot of sexual pain can relate back to some of the other issues. So for example, poor lubrication can obviously increase sexual pain. So using things like those water-based lubricants I mentioned earlier can help alleviate pain. When it comes to tertiary dysfunction, which is a little bit more my wheelhouse directly, things like depression, anxiety, fear, anger, guilt, the emotional responses that impede our ability to engage in intimacy, engage in sexual behavior, medication intervention, so using antidepressant medications. Psychotherapy can be very important. So talking it out, talking about the sexual issues, talking about some of these behavioral changes that you can make in your life. Sexual counseling, so going to a counselor or a therapist or psychologist who specifically deals in sexual issues or intimacy issues, going to a couples therapist who deals with communication issues and working on enhancing your communication. Exposure therapy. So again, back to the idea of openness, just having a willingness to say like, this isn't going to be the way that it used to be, but I still want to really try. And even though it might be awkward or maybe be embarrassing, if you do something enough times, that awkwardness or that embarrassment tends to subside the more you do something. And the other thing I'll say here is de-emphasis on intercourse. So there's a term we call outer course, and that gets back to the idea earlier of erotic touching that doesn't just involve, like, let's stop thinking of sex as just intercourse. It's more than that. It's erotic touching or oral sex or digital stimulation and those types of things. When it comes to relationship challenges and role changes, one of the biggest impediments to intimacy and sexual health is open communication. So either you get really frustrated with your partner, or maybe you're embarrassed to talk about it. So going to couples therapists or working on the communication yourself and saying like, hey, I know this is embarrassing, but it's an important conversation to have. Let's have it, because this is important for both of us. Altered self-image and low self-esteem can be treated very well with psychotherapy or engaging in behavioral ways to reconnect with your sexual identity. So self-exploration, masturbation, just getting comfortable with yourself naked, things like that can be very beneficial. And that's kind of what I meant by self-exploration there as well. Real quick, I want to talk a little bit about iatrogenic effects. Iatrogenic just means that they're physician-induced or therapy-induced. So there are specific medications that can increase sexual dysfunction, not just in MS, but just in general. So the big ones there are the like baclofen, the anti-spasticity medications can cause sexual dysfunction, and specific antidepressants, specifically the SSRIs. Medications like Prozac can actually decrease libido, they can decrease sexual response, and they can decrease your ability to have an orgasm. So there are treatments. You can either augment them with other types of medication, or you can ask your doctor or have a discussion with your physician about potentially switching you to another medication. So for example, SNRIs, medications that are antidepressants that are different than SSRIs, can alleviate those symptoms. And also potentially talking with your doctor about your dosing or the medication scheduling that you're having. So decreasing your dosage or breaking up your dosage more during the day or things like that, so you don't have as much of a strong of a response that causes sexual dysfunction. As it relates to anything above, one thing I want to highlight here that I think can be so important is peer support. I run a peer support group for spinal cord injury, and I can tell you right now that sexual health and functioning is one of the most spontaneous and important topics that consistently comes up when I lead that group. It's something that a lot of people are affected with. If sexual health is normal, sexual dysfunction is normal too, and not just in people dealing with disabilities. So it's very important to have this conversation, because as your physician or your psychologist, we can give you these recommendations, but we don't necessarily know what it's like to go what you're going through. We don't necessarily know exactly what it's like to go through the frustration or the ups and downs of this, but a lot of your peers do. So talking to your peers about what they've struggled with, what's worked for them, what hasn't worked for them can be really beneficial. I often encourage people to increase non-sexual intimacy. So not necessarily just outer core, so not necessarily touching of like sexual areas, but things like petting, touching, massaging, rubbing, you know, like cuddling up on the couch, that's intimate. Just, you know, hugging somebody if they've had a rough day, or massaging their shoulders if they're stressed out. Just trying to increase that non-sexual touching or that non-sexual intimacy. Romantic gestures. So if some of that stuff has kind of fallen out of your relationship, it's important to bring that back in. So hand holding, going on dates, watching a romantic movie, just doing something special for your partner can be really good. Some other specific behavioral methods, like if you were interested in sexual counseling or going to a sex therapist or working with a rehab psychologist, a lot of the things I'll suggest are things like, and I mentioned this a little bit earlier, using visualization techniques. And the cool thing about visualization is it can be a little bit hard at first, but the more you practice it, the better you can get at it. And there are even stories and reports of people who get so good at visualization that they can achieve like even orgasm just through like mental stimulation or getting themselves there mentally. So using fantasy and visualization as a form of arousal. And another thing that's come up more recently and has actually been shown to work in people with MS is what's called sensate focus. This comes out of some really old research by Masters and Johnson, who are kind of like these sex gurus. They're like sexual pioneers and researchers. Sensate focus has to do with learning to limit the judgment that you have about, you know, where you're at right now, and eliminate those expectations and just say, I'm a sexual being and I want to engage in this activity, and I want to remove that judgment or that expectation from it. Generally speaking, it starts with a focus on the present moment. So instead of saying, you know, I'm not sexy or I can't perform, the other person isn't finding this satisfying, those are all judgments. So in observing minds, people who make those kind of judgments think too much, but they feel too little. So the focus on non-judgmental physical feelings. So as you touch your partner, focusing on their skin is warm, their skin is soft, the skin is rough, if the skin is wet, or whatever it may be. Those are non-judgmental, right? They're observational, but there's no judgment assigned to them. And then you move into sensuality over sexuality. So basically what I kind of mentioned earlier, you avoid explicit sexual areas, because as you start to focus on sex as just intercourse, you put a pressure on yourself to perform sexually. So this is more about exploration. So just touching different areas and noticing the responses you get from your partner, and then taking turns. So one person is the toucher and one person's the receiver, and then you switch roles. And then gradually over time, you introduce directly sexual experiences into the activity. Real quick, I just want to talk about the Placent model. I know that this is geared more toward people who have MS and your families and your partners, but just in case there are any providers who stumble upon this or any providers who are listening, it's not just your responsibility as someone who has MS or your partner to address this issue. I think it's our responsibilities as providers and healthcare professionals to create an environment where it's safe and comfortable to talk about sexual issues. So anybody who's a provider, I encourage you to research the Placent Model a little bit better. It's great at encouraging people and giving them permission to talk about sexual activity. I don't want to spend too much time on this. I just wanted to mention it just in case you hadn't heard of it. I think it's very important because it's our responsibility to facilitate this conversation as well. And oftentimes, if we facilitate it, people are more likely to talk about it than just expecting them to mention it spontaneously on their own. I also briefly wanted to talk about dating with MS. Because a lot of times you might not have an established relationship or a partner right now, and you might be going into the dating market and wondering, like, how do I handle this with maybe a new diagnosis of MS? It's more of a complex issue than I can do due diligence in just an hour-long lecture. But some of the common questions I get are when to disclose disability. And one thing I want to say with any of this is there's not a one-size-fits-all answer. And oftentimes people get overwhelmed because they want to make the quote-unquote right answer. And so they wind up not making a decision at all because they feel like they're going to make the wrong answer. Think about it like this. There's not a right or wrong answer. There's just pros and cons, and you have to choose what's right for you. So for example, there was a person with a disability who conducted an experiment where they created two different dating profiles, one where they disclosed the disability and one where they didn't. And obviously, due to stigma, the one where they didn't disclose their disability got more attention than the one where they did. So there's sort of two schools of thought here. If you do disclose your disability, then you might have less interest, but it's also a good way to weed out potential jerks before you have to face the embarrassment or the feeling of rejection. Conversely, if you don't choose to disclose your disability, then you get the opportunity to show them the person you are so they don't only see the disability. So there's pros and cons to both of those methods, and there's not a right or wrong answer, and people often choose one or the other. Another question that I usually get is what to say about your disability. And a couple of things I just want to quickly highlight here is people with disabilities are often placed in an ambassador role where it's like, quote unquote, your job to help people who don't have disabilities understand your disability. And that's not a comfortable place to always be in, and it kind of sucks that you have to be in that role. But I encourage people to be, whatever it is you choose to say, make sure it's something you're comfortable and that you're choosing to disclose. It is your choice to disclose this. You don't owe anyone anything. And then it's consistent with the goals of the relationship. It's consistent with the goals that you have and the potential partner has in the situation. And not disclosing can actually lead to less control than disclosing, because when you disclose, you get to have some direct control over how the conversation goes and what you say and what happens, as opposed to just kind of fearfully waiting in the shadows and hoping that they don't find out, or if they do find out, that they're not going to judge you. It gives you an opportunity to have control over how that conversation goes. And the last point I'll make, especially as it relates to dating, is have some patience with the person you're working with. Allow for a reciprocal conversation and adjustment for the potential partner. It might be difficult for them to wrap their head around what you're telling them to begin with, and they might have questions that are kind of embarrassing or can be a little bit triggering or infuriating. But just remember that through having a healthy conversation, you might ultimately wind up with what you're looking for. It just might be an awkward or an embarrassing or even a frustrating conversation to start with. But that doesn't mean it's a conversation not worth having. So just some of the take-home messages I want to go over again really quick. Sex is totally normal. It's part of human functioning. It's present across the lifespan. Embarrassment about sexual issues are very common. Embarrassment about discussing sexual issues or discussing your sexual health with physicians or with your partner. It's common, but that doesn't mean that you can't work through that. Sexual dysfunction after MS is common in both men and women. It's common in general populations, but it's more common in MS. Sexual dysfunction can be broken down into those different categories, so primary, secondary, and tertiary. So as you think about what some of your problems might be, think about how you could break those down or discuss those with a potential provider or your partner. Effective treatments exist, but they do require multiple disciplinary treatment oftentimes, especially as if you have a problem in more than one area. Patience, self-compassion, and openness are keys to successful treatment. It's not going to fix itself overnight, but you deserve your sexual health and intimacy. You deserve to feel sexy or attractive or whatever it is that you're looking for. And so I think you owe it to yourself to have that exploration and to be willing to be vulnerable and to rediscover that if it's something that you're struggling with right now. So just finding help and next steps, some broad things I want to say real quick. Seeking help. So finding a therapist, people often tell me, well, how do I do that? You can call your insurance, and oftentimes your insurance will give you a list of providers that they cover. Psychology Today is an online publication that actually has a classified section for psychologists. And the cool thing about that is you can filter out by specialty. There's usually a blurb the person writes themselves about like what their specialty is and how they are as a therapist. So it's a good way for you to find a potential match and do some screening ahead of time. Basic Google searches, or even talking to your medical provider, like, hey, I'm having this issue. Do you refer out to a psychologist or to a specialist? I tend to encourage people to seek out therapists who specialize in things like cognitive behavioral therapy, positive psychology, or finding a rehabilitation psychologist or someone who specializes in couples issues or sexual therapy. I included a link there for Sensate Focus. So I've discussed that a little bit earlier, but I included a literal, it's a self-help guide. It's a step-by-step guide on how to participate in Sensate Focus if you're looking for a little bit of self-help or something you can do on your own. The Ultimate Guide to Sex and Disability is a book that I use in my clinical practice, and I often refer patients to pick it up. It's written in very plain and basic language, and it's written with a certain amount of openness and bluntness and brevity that I think is very non-threatening, and it has just an absolute, just insane amount of really good information. So if this is something where you want to go a little bit more of a self-help route, or you want to go a little bit more in depth over some of the stuff I discussed today, it is an excellent book. I think it's like $25 on Amazon. It's something I use quite frequently. Trying to find or connecting to peer support groups, whether they be online or in person, I think can be very beneficial to you, as well as connecting to like different community or advocacy services to be able to find those types of things. And I included my email address down there at the bottom, just in case you were struggling with any of these things, or if you wanted to ask a specific question, you could always reach back out to me. And real quick before we conclude, I just wanted to say, you know, a special thanks to MS Focus and to Deborah Foreman for inviting me to do this. I really enjoy doing this. This is awesome. And I hope that you get something out of this. A special thanks to Dr. Kelsey Hewitt, who's my wonderful fiance, who usually helps edit and helps me review these lectures so that they're really good. And also I want to thank a lot of the wonderful people that I work with who inspire me and who allow me to be able to do this work.
Thank you so much. That was wonderful, great information. We are ready for questions now, and nice to see your face again. So if you have a question or you'd like to make a comment, you can actually go into the chat area and type it in, or you can go to the Q&A section and put it in. If you'd like to make your question anonymous, all you have to do is hit the little area that says anonymous, the little button, and then it will come through to us anonymously, and I won't mention your name. And if you'd like to raise your hand to actually speak, all you have to do is go to the bottom of the screen, hit the raised hand feature, and then I'll have to unmute you, just allow me to do that and we can go from there. So you did answer one of the questions earlier. I think I just want to make sure, because at the very beginning, Vicky had asked this question and I thought you touched on it, but I want to make sure that she got her answer. And it did say, where does libido fall? Is it primary, secondary, or tertiary? And so I think I know the answer because you touched it, but let's make sure. So if you could just answer her, that would be great.
So it could be a little bit of everything depending on what's affecting the libido. So obviously there's that complex neurological response that happens between the brain and the spinal cord. So it can be primary. A lesion can directly affect libido. And then tertiary things like depression and secondary things like fatigue can also affect libido. So a little bit of each, even though I kind of put it in the primary category, depending on what's causing it, it can be different things.
Okay. I also have, a lot of things that you said just resonated with me, and I don't have MS, but I know so many people with MS, and now I'm in a menopausal state. So, and I'm sure many of them are also, which just adds, that much more to deal with in terms of your sexuality and your intimacy. So what I wanted to mention to you, and I know that you know this, but I have a very, very close, she's like a child to me, who's a gynecologist. And she tells me that women don't share with her what's going on with them. And she literally has to pull it out of them because she sees what's going on. And she says to them, are you experiencing this? Are you having problems? Do you want to discuss it? And people don't want to discuss it with her. And she's the perfect person to discuss that with, in addition to any therapy that you want to go to. But if you're having sexual dysfunction, speak to your gynecologist, right? I mean,
absolutely. That embarrassment that's associated with it. One thing I want to highlight is, like, if you bring up any of these issues with your MS doctor or a gynecologist or a urologist or a psychologist, whoever it is, I promise you it's not going to be the first time they heard it.
Yeah, I'm sure. Well, this is what she tells me. There's also a type of vaginal moisturizer that's called Reverie, and I don't know if you've ever heard of it before, but it's something that, I mean, I believe in trying to get your friends to talk to you about this, because they're your friends, you love them, and it would be nice, like you discussed, talking to your peers, whether it's people in your support group, whether you're a man or a woman, you already have a relationship with them, or your friends that aren't in your support groups, and talking to them and getting them to discuss what's going on with them, because just because you have MS doesn't mean that what you're going through is strictly related to the MS, right?
Absolutely.
So yeah, I agree. Let's see, we have a question. Where can we find the woman's vacuum?
I Googled it because I've actually found it in a research study and I never had heard of it. And they actually have a website. So Eros has a website where I guess, I don't even think you have to have a prescription. It looks like they sold it directly on the website. I don't know if that's something, it's FDA approved, so I don't know if insurance covers it or anything like that. But there was like a link to buy it, and it's like $200 or something like that, I want to say.
Okay. Let's see, we have an anonymous question. How can a person that is bedridden have safe sex that have problems with incontinence and leg pain?
So I think that's a wonderful question. And it's one where I can't give you a very specific answer without kind of like talking through it. That would be something to have a very kind of in-depth conversation on what works and what doesn't work. So for example, in my work with spinal cord injury, I know people with sort of high-level cervical injuries where they have a loss of sensation below neck down or chest down or things like that. The sex slings, if it's something that you can transfer into, are very popular. So I know people with like the high-level spinal cord injuries where they're immobile, like I said, below the neck down, that use those things. The different positions could be useful. That would be something that I would either talk to your physician about, or if you have an occupational therapist, most occupational therapists are actually trained in sexual health and responses, especially if they work with people that have neurological conditions or disabilities.
Great.
But it is possible. That's kind of the main takeaway I want you to have, even if I can't give you a more specific answer.
Okay. Someone has asked whether we can show your email address, and Casey, if you could put that into the chat area, we can give everybody his email address. That was very nice of you to offer that. So
yeah, it might take me a little while to get around to you, but I promise that I'll flag it and I'll get around to it when I can, because I know that some of these things can be difficult and sometimes people need a little bit of a compass.
Dee wants you to know, thank you so much. This has been really good information that she wishes that she had when she was married. This would have been good for him to see, her husband. Thank you for discussing. So I wanted you to know that. We also have someone, let's see, can a person with MS get pregnant?
You know, the one thing that I will say that I didn't include in this, and I'm sorry I didn't include in it, I'm actually not sure the answer to that question. I think it would probably depend on what's affected and how it's affected. That's another important thing I should have said about at the onset of this conversation. Obviously, MS is so profoundly different from person to person because the lesions can occur in different areas. So you could get 100 people in a room with MS and none of them look alike. So that would be a question I might address with your OB.
Yeah, I know from working with the Multiple Sclerosis Foundation, we have lots of people who do get pregnant. And it is something, you're right, that would be best discussed with your neurologist, your gynecologist, all those specialists before you were to get pregnant. So we have another question. It says, I'm a female. What, if anything, can be done for lack of or interrupted sensation during intercourse? I assume this problem is due to the nerve damage for that area of my body.
So if the question's more directly about enhancing sensation, to my knowledge, there's not necessarily anything you can do in that moment to enhance sensation. But that's usually when I encourage people to think about, well, let's move away a little bit from sex as just the intercourse, but the experience of being with another human being, or if you're not getting sensation vaginally, well, then touching other erogenous zones or engaging in touching in other ways, or communicating with your partner on how they can enhance it, or engaging in sexual fantasy, you know, imagining and getting yourself aroused.
So you made a very good point earlier about how before you actually had intercourse with someone, there were all kinds of ways that were stimulating, right? All kinds of touching and kissing and things like that. So I suppose if you went back to that, we forget about those things. We forget about how good it is to have somebody rub your arm. It's delightful, right? And that doesn't go away. So let's see. Any specific lubricants that you can actually suggest? And maybe we can
None particularly. You mentioned that one, so that sounds like that would be a good opportunity, and I had not heard of that one. I know that the research really just indicates making sure that, I mean, don't just use anything. I can't give you a specific one, but I will suggest that like things like hand lotions and Vaseline or things like that aren't necessarily directly indicated for sex, you should probably avoid those. Obviously, lipid soluble based oils, you should avoid those. Like the ones that you can find in adult shops or sex shops or water soluble, and they're meant and designed specifically for intercourse. So those would be ones that would be more appropriate. If you have a concern, if something you want to try could cause some sort of damage or allergic reaction or things like that, I would encourage you to talk to your physician.
Okay. I know that the Reverie is a suppository, a vaginal suppository. So for people that have MS that have difficulty with their hands, that might be a little difficult, but it could even be something to be used as a couple, you know, that maybe to get both people involved in that, as opposed to just the female being in charge of taking care of her body and the male being in charge of his body, maybe it would be fun just to be involved in that. But you'd have to have open discussion, right? You'd have to discuss that.
And I love the way you say that too. So remembering that with intimacy and sex, it's a shared responsibility. And I like the way you said that. It's not like you're just responsible for you and your partner's responsible for your partner. It's mutual, right?
Yeah. I once went to it was a meeting, and it was about it was a couple meeting, and you were talking about how do you do something that makes the other person happy. And this one man said, well, I for 1 week did everything that I thought would make my wife happy. I did everything that I thought would make her happy, and at the end of the week she still wasn't happy. And so at the end of the week the wife said, well, you didn't ask me what would make me happy. If you had asked me, I would have been able to give you a list of what would have made me happy. So there, in and of itself, you need to communicate, right, for it to work out well. So, and so much of what you said went back to that. So I liked it. So, and yes, we can get a video. This video is going to actually be on our YouTube channel and on our SoundCloud. So somebody asked if they could get the video uploaded if they came in late. In a week or two, this will be available to everybody that missed it or people that want to see it again. So we'll be able to do that. Let's see. Let's see if any other questions come in. Are there any good, safe, over-the-counter medications similar to Viagra that you can recommend?
Not to my knowledge. I can't think of any offhand, and I know a lot of the ones that say that they can are kind of suspect. I don't think they have FDA approval. So I can't think of any that are or that have been approved, especially like I would look for things that are FDA approval. There's definitely a snake oil market for like sexual intimacy drugs and those types of things. So avoid those.
Let's see. We'll wait for a second and see if anything else comes through. If anybody has any questions, again, if you'd like to do it anonymously, you can just hit the little button that says anonymous and we'll get that through. And I did put in the name of Reverie as the lubricant. They even have a Facebook page that is great. They'll answer questions. The company comes on and discusses it. I don't work for them. I'm not selling it, but I'm familiar with the product. So.
Real quick while I'm on video, I just want to hold up this book. Again, like I don't know the authors of this book. I'm not selling this book. I don't get anything for this book, but I do like it. And that's what it looks like. It's a very, very good resource and reference.
And again, if you missed that, you can just look at this video in another couple of weeks and you'll be able to get that book also, unless you caught that really quick, Casey, and you can type the name in. Oh, can you hold it up for one more second, that book?
Absolutely.
Okay.
Like I said, you can get it. I got my copy, just you can get it anywhere, but I mean, I got mine on Amazon, kind of like how everybody shops nowadays.
Right.
I'd also like to mention that for anybody who has a Facebook account, they'll be able to view this video again today. As soon as we close out the live session on Facebook, it'll take about 5 minutes, and then they'll be able to find it from the Foundation's Facebook page.
Good. Also, you mentioned about getting married and whether people get married with MS. I think you talked about that, right? Whether to disclose that when you're dating or not disclose that when you're dating. And I'm familiar with some pediatric patients that are clients of ours, and they're dating and they're I guess telling people, and one of them is even getting married soon. She was pediatric and now she's getting a little older, so she's getting married. So yeah, I guess it's all about being honest and when you're ready to do that, right?
Absolutely. And I've met a lot of people who found their life partners after their injury or disability or diagnosis.
Mhm. Wonderful. If we have any more questions, now is the time to ask them. Up close and personal with the doctor. Nope, I don't think so. Someone's saying thank you so much for doing this presentation. It has been needed for a long time. That's very nice. It's true. It's not one of those topics that we talk about often, but it is really needed. So I'm glad it's now available, especially to everyone who couldn't attend. They'll be able to go in at their own leisure and be able to see this for years to come. So.
It's the most common thing that nobody wants to talk about. It's always kind of fascinated with me that how normal it is and how reluctant we can be to talk about sex.
Right. Right. Even with the people that it's most important to.
Even with your sexual partner.
Right.
You know.
Exactly. So thank you. Anyway, thank you so much for doing this. We are so happy that you're coming back to us. We really love when you present for us. It's all the time we have for now. If you've missed any part of this conference, as I said, it's going to be replayed on our msfocusradio.org and available on demand on our MS Focus SoundCloud page and our YouTube page. Remember to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference is going to be this coming Monday, September 27th at 7:00 p.m. Eastern Time. It's going to be featuring Dr. Pearl Werfel, who's a PhD, who's going to be discussing some successful non-medical techniques for easing pain and discomfort in MS. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Brown, who was kind enough again to take time out of his busy schedule to share this information with us. Goodbye, everyone, and we hope to see you next time. Thank you.
Thank you.